Thank you again. It's helpful that the speakers before me have done an excellent job in showing many of the carotid stent procedures. I will share some data in the context of acute stroke because there are always questions what to do first, whether we should do it or not, how are the outcomes. So I will start by showing and sharing some of the data that was from these recent endovascular trials. First of all, what do we define as a tandem occlusion? It's an occlusion or near occlusion or high-grade stenosis of the extracranial carotid in the setting of an ipsilateral cranial carotid occlusion without an intracranial vascular occlusion is not a tandem occlusion. It's an acute or chronic extracranial cervical IC occlusion that may be presenting with acute symptoms. In this case, there is no intracranial occlusion, and this is a special category of patients presenting a diagnostic or treatment challenge. And it's very important to differentiate between pseudo-occlusion and true occlusion. Pseudo-occlusion can happen due to a large intracranial IC, a terminal thrombus or embolus with retrograde stagnation or slow flow. So the question is, what do we do with a patient like this who has a high-grade stenosis of the left internal carotid artery origin and has an ipsilateral intracranial stenosis? I know we have our own approach and view, but let's look at what the clinical trials showed that were done for endovascular therapy. So the question is there evidence to consider patients with tandem occlusions for endovascular therapy? What is the incidence of tandem occlusions? And we're talking about the anterior circulation. And what is the appropriate treatment strategy, A, in terms of endovascular therapy, and B, in terms of peri and postoperative antiplatelet management? The data regarding IVTPA is not very good. Now, in the recent clinical trials, these columns shows the trials that allowed inclusion of patients with a tandem occlusion for randomization. Mr. Clean, Escape, REVAS-CAT, Diffuse 3, these patients allowed tandem occlusions to be included. Patients in these trials, Fifth Prime we were part of, Dawn, these trials excluded a tandem occlusion from randomization to either endovascular or the medical arm. So there were 4 clinical trials essentially from which this data is gathered. If you look at Mr. Clean, the incidence in Mr. Clean of tandem occlusions was about 30%. If you look down here, extracranial ICA occlusion in the intervention or the control arm was about 32% in the intervention, 26% in the control. So average was about 30%. And the results showed that in patients with a tandem occlusion, there was some treatment effect in favor of endovascular therapy. You can see that the results cross unity, so it's not very statistically significant versus patients with isolated intracranial occlusion. There was a clear benefit in favor of endovascular therapy. If you look at Escape, the other big trial, the incidence was around 13% tandem occlusions. And patients with a cervical carotid occlusion with an ipsilateral large vessel occlusion, there was clear benefit in favor of endovascular therapy versus medical management. Escape also did a subgroup analysis of patients who had a tandem occlusion in the endovascular arm. So amongst 30 patients with tandem occlusions, 17 had extracranial occlusion treated acutely, 13 the extracranial occlusion was not managed acutely. And there's different strategies. Stenting was done, delayed stenting or endarterectomy. In this case, where they were acutely treated, this is a nice breakup. In 10 patients, they did the extracranial first. In 7 patients, the intracranial was done first. And the various techniques were used: angioplasty, aspiration, angioplasty, loaner versus stenting. And in ESCAPE, if you look at the outcomes, modified ranking of 0 to 2 at 90 days. I don't know if I'm stepping on something. Okay, there it is. The outcome between tandem occlusion and patients with isolated occlusion, there was no difference, even though it says 60% for tandem occlusion, but the results are not significant. So, no difference between outcomes. And in the endovascular group, patients with acute intervention or no acute intervention, there was no difference. So the data did not show that these patients or the outcomes did not differ whether the patient extracranial carotid was occluded as part of the acute stroke procedure or was treated in a delayed fashion. VIVAS-CAT study in Catalonia, Spain, ipsilateral cervical occlusion was about 22%, and they also showed a benefit odds ratio in favor of endovascular therapy for tandem occlusion. Diffuse 3 was the last one. This was a little bit looser criteria and a looser definition, but similar outcomes in favor of endovascular therapy. There were different tools allowed for that, and as I said, the definition of the extracranial occlusion was a little bit loose. It wasn't necessarily cervical occlusion. Typically that occurs at the bifurcation or the cervical IC origin. Hermes is a pooled data from their endovascular trials, and this is the incidence about 21-22%, which is similar to our own experience of tandem occlusions. So it's not insignificant. 1/4 to 1/5 of the patients can have a tandem occlusion, and the benefit of the pooled data was in favor of endovascular therapy versus medical management or IBTP alone. It confirmed a benefit for endovascular therapy. However, there was such a heterogeneity of treatment that there was no clear pathway to demonstrate that one strategy of extracranial revascularization is better than the other. For instance, is angioplasty alone best? Is stent best? Do we treat the intracranial first or the extracranial first? And I know we have our own preferences and choices, but again, nothing is dogmatic. It is always patient-specific. So the question, is there evidence to consider patients with tandem occlusions for endovascular therapy? The answer is yes. What is the incidence of tandem occlusions in anterior circulation? The answer is about 17 to 25% based on these randomized controlled trials, which is level 1 evidence. What is the appropriate treatment strategy in terms of therapy or perioperative and postoperative antiplatelet management for this? If we look at what was the strategy in these clinical trials, it is fairly variable. 85% received IVTP, 74% down to 48%. The intraoperative antiplatelet therapy typically is a combination of aspirin and clopidogrel and variety of use of the group 2B3A inhibitors. And now with next generation antiplatelet therapies that are active metabolites with shorter half-lives, don't need conversion, quicker onset of action, this may change. Postoperatively, it was fairly consistent with aspirin and Plavix, clopidogrel on these patients who were treated endovascularly at the time of the index procedure. Then there is also variety in approaches, stenting done first, followed by thrombectomy, stent followed by thrombectomy, thrombectomy followed by stent. So what is the answer to the third question? The appropriate treatment strategy, again, it's not written in stone, it's not dogmatic, it can be variable. Commonly used antiplatelet, dual double antiplatelet therapy or aspirin, clopidogrel, or next generation antiplatelets, P2Y12 inhibitors, versus the use of group 2B3A. No clear approach, but the conclusion is probably avoid stent in the acute stage if possible. Our own experience, our incidence at our center was 16% of all patients treated had a tandem occlusion. Our strategy is primarily around aspirin and clopidogrel. We only have oral aspirin, no IV aspirin. And extracranial occlusion type, where we counted tandem occlusions, were predominantly patients with completely occluded, acutely occluded extracranial internal carotid artery and heavy underlying chronic atherosclerotic disease, and then a distal embolus. We achieved reasonable revascularization, some not so good outcomes, 33% good outcome, assuming patients lost to follow-up had poor outcomes, about 80% recanalization, fairly high mortality. So in this patient with a wake-up stroke, typical dawn patient, has, but would have been excluded from dawn because it did not include tandems, left MC occlusion, left ICS cervical occlusion, etc., has critical occlusion, which necessitates some form of therapy to reach the intracranial circulation. In this case, angioplasty alone was performed, followed by the intracranial thrombectomy, and stenting was performed in a delayed fashion 3 days later. Another patient, 52-year-old, IVT PNA stroke scale of 5. Now, this patient presented initially with an isolated cervical ICA occlusion, no intracranial vascular occlusion. NIH stroke scale worsened from 5 to 17. So this is a particular class of patients in terms of management, that there is nothing intracranial. The patient is clinically doing fairly well, but we know they're acutely symptomatic and there's an occlusion. The initial medical management of these patients is always in the ICU setting, very close monitoring of the blood pressure, hypertension, maintenance of relatively high blood pressure, about 140, not just with fluid, but preferably with pressors, and a very close monitoring. Versus the other thought is, should we go and open the acute occlusion, which doesn't have an intracranial occlusion, and take the risk of converting an isolated cervical occlusion to a tandem occlusion by trying to open up the carotid artery? The answer to that is unclear. Shall I stop? Yes. Okay, so I'll skip over these cases. You've already seen excellent examples of tandem strokes. In our practice, we will always assess the intracranial circulation first. We will start with an angioplasty if it is required, open the intracranial circulation, wait to see if the carotid remains open, start the patient antiplatelet therapy, stent the patient after 2 days or 3 days. I'll skip these, quickly show the extracranial vertebral. The vertebral arteries are a little different because we have 2 vertebral arteries. It's important to distinguish between the dominant versus the non-dominant. A non-dominant occluded vertebral artery is not that critical. Anyway, this patient has a heavy calcification. The dominant vertebral artery is occluded. The non-dominant is open. So in this case, we put a microcatheter in the left vertebral artery to administer intraarterial TPA, so the patient starts receiving some local thrombolytic effect. As a side note, we fairly commonly used intraarterial TPA. While the intraarterial TPA is being administered through the left vertebral artery, non-dominant, we puncture the other side and revascularize the right vertebral artery origin using a coronary bare metal stent. And once the stent was placed, there was no need to open the intracranial circulation because it has thrombolized and the flow took care of the rest. We'll stop at this point. Thank you.